We are now live on, whoops, hold on a second. We are not. Oh, Stacy, we've lost the Facebook page connection, so we're going to have to take the recording from YouTube and bring it on over. And maybe you can put that link onto Facebook right now because we've had a break of that particular stream. Good afternoon, everybody. It is about 2 p.m. here on the East Coast, which makes it about
11 o'clock
on the West Coast. And we are excited to announce the launch of a brand new member of the HCMA Recognized Center of Excellence family to Virginia Mason in Seattle, Washington. And their program director is with us today, Mariko Harper. Welcome, Dr. Harper, and welcome to the HCMA family of programs.
Thank you, Lisa, and I'm super excited to be here and to join the Hypertrophic Cardiomyopathy Association family of COEs.
So we have your contact information up on the screen right now. We're going to bring that up a little bit later, but I thought we would talk for a moment or two here about why it is that you decided that an HCMA program was something that you were seeking for your institution, and how it is that you developed an interest in HCM.
Yeah, well, one thing is I practice in Seattle, Washington, and it's important to know that this part of the country has a paucity of HCM and cardiomyopathy care centers. I did my fellowship at the University of Washington once upon a time, and I had a specific interest in cardiomyopathies, genetics. I have a master's degree in genetics, and I trained at the UW and did a dedicated year in an HCM clinic. I moved across the street to Virginia Mason almost 8 years ago now, and I started seeing patients with HCM, but did not really take that full leap to formalizing and creating a comprehensive program until maybe the last 3 or 4 years. It's a really exciting time, as you and most people here on this call know, for HCM. And it was about probably 3 or 4 years ago, before mavacamten was moved, when it was still myocardia. And I started doing some consulting and advising at myocardia, really as an echocardiographer and as a clinical cardiologist with an interest in HCM. And it was very clear that cardiac myosin inhibitors were going to be a game changer, or at least that's what I thought. And in this part of the world, where we were sending out most of our severely symptomatic patients to large volume myectomy centers like Mayo and Cleveland Clinic, there was a lot of patients who couldn't travel. There was a lot of patients that unfortunately were living with their symptoms who we were a little bit stuck here.
Yes.
We just did not have the tools. And this was a really exciting time to start thinking about, hey, maybe not only is this drug going to be a really helpful tool in the toolkit for HCM, but maybe it's time that I step up along with my colleagues and friends in the region to bring and create a program and bring this subspecialty into our patients' backyard so that they didn't have to travel, but that the care would be here where they need it. Because, program building can be really fun. The science is fascinating. I love cardiology. I love the physiology. It's why I'm a cardiologist. And I do love this specific patient population. But at the end of the day, it's really about providing and filling a need. And this is one part of the country where I think we both agree there is a real need. There's a lot of patients, and a lot of them are underdiagnosed, misdiagnosed, probably even more than the national average, because there hasn't been large comprehensive programs. It's not the East Coast where there's one on every city block.
Yeah, we have a lot more coverage over here. It's not quite one on every city block. You might have to go 2 blocks sometimes in New York, but it is a challenge to bring this type of care throughout the country. And the Pacific Northwest has been an area that I have long been looking towards for growth and access to care for those individual patients. But building out systems, it's different in every part of this country, right? When you go to Pittsburgh, nobody wants to cross a bridge to go to a different hospital. And I learned by going up to Seattle that people don't want to go across big bodies of water, and they want to be able to access their care conveniently. And that
Absolutely.
becomes more problematic. And when I remember when I came out to do the visits out there, and people telling me, well, when they can't get through the pass because of the snow in the winter, I'm like, that still happens? I didn't know.
100%.
I didn't know.
So
Is
there's all these interesting but complex issues that come up that you don't really realize until you're starting to build a program. So there's the medicine, there's the science, there's the gold standard in patient care, making sure we're providing the very best. But then these unique social circumstances and system issues and environmental issues and geographical issues that we need to deal with. But this was also in the era of COVID and then post-COVID. So virtual care exploded. So it was a really good timing. I do a vast majority of my visits virtual. I love to see my patients ideally once a year, still in person, put the stethoscope on. But a lot of our patients, especially those on CMIs, we can do this visit virtually. They're getting their echoes. I know what their heart's looking like. So we really do get to keep them not only in the state, but in their own community. And that's been a huge game changer in how we practice medicine and how we deliver care, I think, to our patient base. But I still travel, for example, 30 miles north once a month and about the same south once a month to see patients who use that 40-minute commute down to Seattle and the parking issues they don't want to do. And we have multiple regional access sites and other HCM cardiologists and providers in the region, so that hopefully we can make it more accessible and convenient for patients to get the care that they deserve.
So you had to build a team. So let's talk a little bit about who's on your team.
It's a pretty big team, and it started off as an idea. And honestly, I'm not in a large academic center. We are a teaching hospital. We have residents, we have cardiology fellows, we have the Benaroya Research Institute, but we did not have all of this infrastructure to build a subspecialty HCM program. But fortunately, being a little bit on the smaller side and being innovative meant we could be more nimble. First came my surgical partner, Dr. Bob Moraka, and he had experience in doing myectomies on the East Coast. And together we decided, well, this is one area, even in the era of CMIs, that we should really look at trying to develop a surgical arm in addition to a medical arm. Now, this is really difficult to do. And as you know, not everybody should be doing myectomies. Volume and experience really matter. And so we reached out initially to Cleveland and Mayo Clinic, and we had this relationship. And again, this was around the time of COVID. So they were offering, like Dr. Durrani was offering virtual consults and willing to pick up the phone to kind of help us for the patients who couldn't travel. So we were really transparent with our patients, but we slowly built out that surgical arm, and he partnered with me. And then we had a medical assistant who became my nurse and a nurse coordinator. So like very homegrown, Alex Chan, who's amazing. So he is going to be the person who picks up that phone. My patients all know him. He's going to be taking care of those portal messages, scheduling all of the complex visits, all the CMI appointments, whatnot. And then a little over a year ago, Dr. Jill Jezerim, PhD, joined as my research partner, and she's also our system coordinator. So that's sort of our large leadership team. And in addition to that, we have Dr. Lucy Lin, who's down at St. Joseph's Hospital in Tacoma, a bit more down south, and she has an HCM clinic. Dr. Sajeen Adhikari up in St. Michael's on the peninsula. And then we have 2 alcohol septal ablation experts. Granted, we don't do a lot of alcohol septal ablation, but it is an important tool to keep in the toolkit. And then we have a few electrophysiologists and 3 cardiac pharmacists dedicated to running our cardiac myosin inhibitor clinic, which runs 5 days a week. And they see patients. They see our almost 100 MAVA patients regularly and work. And unfortunately, we're all in the same place. So while they're doing a lot of virtual care, we meet together and they make up some of our research team as well.
And in the advanced heart failure patient, you work
Dr.
collaboratively with.
Dr. Banu Gupta is our system director for advanced heart failure, and he has experience in cardiomyopathy as well. And he joins our team, and we actually all meet on a multidisciplinary conference every 2 weeks virtually. So all of our complex patient care is discussed. Do they need a defibrillator? Yay, nay, let's review the imaging. I'm grateful to have so many different advanced imagers, including radiologists, right? Not everybody has cardiac imagers reading all of their MRIs. So we all meet together so we can provide the imaging expertise with the clinical expertise, get that nuance, and make that decision as a group, really, as far as recommendations when there's things that are a bit in the gray, or when there's, like in many cases, more than one option available.
So you've talked about our toolbox, which is ever growing, and how we grow the toolbox is through things like clinical trials. So can you talk a little bit about some of the trials you've been part of in the past and anything that you might have actively moving forward?
Absolutely. So currently we have phase 2, 3, and 4 clinical trials in collaboration with our Benaroya Research Institute, which is just on campus here at our Seattle, Virginia Mason. And currently we are enrolling patients in a phase 3 non-obstructive clinical trial for symptomatic non-obstructive HCM. That's the Acacia with Cytokinetics, where I think we're finishing up in the Discover registry for MAVA. And then we have for obstructive, the Edgewise trial as well, and some non-obstructive in that arm as well.
So prior to current, were you involved? You mentioned myocardia earlier. So I'm going to guess you had some knowledge and involvement in the early myosin inhibitor trials as well.
Well, I personally was not, because we did not have a big program yet. We started from scratch. So it was more of like as a clinical consultant that I was involved. So we really did build this program from the ground up. And so about 4 years ago, we started, and we've been ramping up quickly. And I've gone from being an imaging cardiologist with a background in cardiomyopathy to essentially being 100% HCM and genetic cardiologist in the last 4 years. So
I don't see a reason to be in any other form of cardiology. I think that's perfect. So we're loving that. So you built a team, you've built clinical trial capacity. You have a surgeon, but we're still referring the complex surgeries to higher volume surgeons. You have an electrophysiologist who's handling both sudden cardiac arrest assessment, device placement, and atrial fibrillation management.
And complex VT as well. We're very lucky to have Dr. Ether Razik, our system director, who comes with many years of experiences and has the most amount of experience in complex VT in the state of Washington. So
lovely. So we are on the eve of Heart Month. It starts in less than 12 hours. We start the month of talking all things heart. And having just joined our Center of Excellence Network and coming into Heart Month, what do you think the most important things are for people within our community to know about access to care now in Seattle?
I think knowing that you have a comprehensive HCM center that's been vetted and is really passionate about continuing to grow and also collaborate with other centers, both in the region and beyond, that we are available in your own backyard, and we would love to see you. And we're building out access. So hopefully it won't be months to get in. Hopefully you're going to be getting in within a few weeks, and you'll have a real person to talk to when you pick up the phone. And we would love to take care of you and work with you. And we have a lot of other ideas as well going into 2025 and 2026, raising awareness, bringing more research, our own investigator-initiated research, opportunities for patients to get involved in advocacy programs. There's a lot that we'd like to do and really collaborate with our community.
So we've already started the plans to help get the community more engaged. And we are planning an in-person HCMA meeting in Seattle. I think we've identified Belle Harbor as our location. And we are working on signing those contracts shortly. So we will be out in the end of July to come with an educational offering from HCMA with our partners in the region. So stay tuned for that. Save the date and agenda coming out in the next couple of weeks. And we really need to get the Pacific Northwest the care that they need, and sharing voices, sharing stories, sharing the losses that we've even had in the community. We don't have a presence in the Pacific Northwest yet, and we're going all the way up into Alaska with some of these efforts as well. So I really encourage anybody who is in the Pacific Northwest who has been kind of saying, well, this is the closest I can get to good care, to know that there's some really great care now available. So,
and you know what, Lisa, I've just started saying, hey, it hasn't been announced yet, but just save this date for some of my patients that I'm seeing. And the more stable ones, I'm only seeing them maybe once a year, or maybe at most once every 2 years. And every time I bring it up, they're so excited. They're like, oh, I'm going to put this on my calendar now. I think there's a lot of enthusiasm. There's a lot of people wanting to meet other members of this community, to also network with you and your team, and to really get the word out there. So I think it's going to be a fantastic turnout, and it's about time.
I hope so. So when we come out to do site visits, for those who don't know the inner workings, we typically will pull together what we call a meet and greet. And that's just we don't tell them what center we're evaluating. We don't talk about that, but we try to get members of the community who have not had the opportunity to be in a room with people like themselves. And we'll typically get, a handful or maybe a dozen or two people there. We had 40 people sign up just for a meet and greet in Seattle. So we know that they're there. We know that they're interested, and we will continue to grow their advocacy voice and hopefully help change laws in the state of Seattle, state of Washington, so that we're looking at family heart health history as a matter of screening children for the identification of families who are at risk of not just HCM, but other forms of genetic heart disease. So that's where we can all lift things a little bit better and a little bit faster with more hands. And that's where we get our patient advocates involved. So we have trial capacity. You have a team. You have the ability to be seen in the center, or you have these remote locations 30 miles north and south or thereabouts of Seattle proper.
And that's just from me. With my colleagues down in Tacoma, they go down to Gig Harbor, and then all over the peninsula. And also I have a license in Alaska. So I actually have many patients on CMIs who come down to Seattle for initiation. And then once they're more stable, we get a little bit more creative to minimize the amount of travel. But I do a lot of virtual care with rural parts of Alaska as well. And hopefully working on that compact license to get what we call the WAMI region. I think you learned about that when you came out.
I did learn about WAMI. Why don't you tell the rest of the listeners who aren't from WAMI what WAMI is?
So WAMI stands for, let's see if I can get this right, Washington, Wyoming, Alaska, Montana, and Idaho.
And if you add an O, we get Oregon, and we get WAMI-O.
WAMI-O. Oregon has a great program. But the WAMI region, there hasn't been historically any large center. There's been no COE. There's a few colleagues who are doing great work that I partner with in some of these states as well, and we share patients, and I know who to refer to when they need somebody to get an echo in or to see them more locally. But we do have a robust program that is very telehealth friendly with good care coordination. So right now, we have a strong pathway for relationships with Alaska, and I have my license, so it's very easy for me to prescribe virtually and whatnot. But we're working on building that footprint out to the WAMI region, where I think there's a lot of patients who, it's not just with clinical care, but even just with education about getting screened, right? It's the advocacy bit. So it would be wonderful to help really bring that entire WAMI region and be part of what I've always referred to as the hub and spoke model. I think that's what we need a little bit more of. All the COEs, no matter how many you add in the next couple of years, and it's kind of a popular time right now to build these programs with more tools and accessibility to keep it in your home state. But even if you have a dozen more programs in the next couple of years, there are more patients than I think any of us really can take care of. And so that would be the strategy that I think is important, especially in this part of the world, country where I practice.
I don't fully think that people get the whole idea at this point. There are approximately low end 600,000, top end 1.3 million people in the United States with hypertrophic cardiomyopathy. Not all of them are going to be symptomatic. Not all of them are going to require the same level of care. But right now, best data we have is we might be approaching 300,000 identified. That doesn't mean that 300,000 is optimally managed. That means maybe 50 to 60% are optimally managed. And I just started the process yesterday with a new program. And the first thing we ask programs to do is look internally, what's going on inside of your current system. And they had 2,400 patients that they could identify with HCM. But when they started breaking down who had what done, 111 had an MRI. And you're like, where are the rest of the MRIs? Where are the rest of the stress echoes? Where's the genetic testing? So as we develop a center, they're cleaning up what they're doing internally. Like, people have been diagnosed, they may or may not know it. And how do we make sure their care is optimized? This is one of the first steps of any program. So we did that with your programs, and we found where all the gaps were when we cleaned them up, and we make sure that every patient has access to the center, that they've had all of the appropriate testing, they've had risk stratification, they've been educated on who in their family needs to be screened and how and when. We've talked about the use of genetic information, either for family screening or clarification of diagnosis, to make sure you're not one of the mimickers out there. So we're working really hard to make sure every patient with HCM is optimally managed. And that was a real big challenge in the Pacific Northwest until the past year or so for us. So you're going to be busy.
I think so. I mean, using the estimates out there, right? 1 in 200 to 1 in 500, we're looking at a conservative 39,000 patients in Washington State walking around at risk or with hypertrophic cardiomyopathy. And none of us have even a fraction of those numbers in our center, not even close, right? Many of them are probably not even ever seen a cardiologist, period. Right. So we have a lot of work to do. And some of them are, have other things that we can now treat. And the sooner we get them in, the sooner we can treat their other, what we call the phenocopies, the mimickers, these other phenocopies. So there's a lot of reasons that all of these patients with potential hereditary and non-hereditary big heart syndromes and conditions need to come in and be evaluated.
So as you come with your genetics hat on, along with others, let's just take a minute to explain why knowing your thick heart's origin story is important. So if I have myosin binding protein C3 in my family today, there's actually a clinical trial for people with our mutation for gene therapy. But what if I had ATTR or a GLA mutation for Fabry's disease? Does the treatment change drastically?
Absolutely. As you know, right? So when we come in and we see big hearts, big, thick hearts, not all of them are HCM, although it is the most common hereditary cardiomyopathy in the world, and maybe a prevalence between 1 in 200 to 1 in 500, but not all of them are. And one of the most common things that gets misdiagnosed or underdiagnosed as HCM is cardiac amyloidosis. That's there's several different types of amyloid, but it's important to know what type you have, and that comes in through this process. If you have AL amyloid, it's, we need to partner with an oncologist. There's chemotherapy type of regimens to help delay the progress or really even cure, depending on the therapy. But what we're really talking about, most of these patients, as you alluded to, it's TTR amyloid, transthyretin amyloid. And there's two forms. One, which is more de novo, it's non-hereditary, but there is also a hereditary form. And until a few years ago, amyloid, much like HCM a decade plus ago, was considered very morbid, very scary, very rare. We now realize it's not nearly as rare. It's not nearly as morbid, but early diagnosis is the key, because there are treatments like stabilizers to treat and delay the progression. But there's also really, really exciting things going on in the amyloid space to try and deplete the amyloid. And we know that the sooner you get identified and the sooner you start being treated for the amyloid, the better your outcome. And amyloid does have, unfortunately, a very late diagnosis. And oftentimes patients are very symptomatic with heart failure symptoms. But there's a lot of opportunity we can pick that up sooner. And it's not just amyloid, right? You mentioned Fabry's. Sometimes we miss it. In certain patients, Fabry's is a different type of genetic kind of makeup and how it's passed on. So when we're talking about HCM, we say it's something called autosomal dominant, meaning you essentially inherit the HCM from either mom or dad. And there's a 50% chance that each and every one of your biological children will inherit the HCM from you. With something like Fabry's, it's a bit different because it's on the X chromosome. So there's a gender difference in presentation. We can't always just check enzyme levels, but you can check genetic levels. But there is something called enzyme replacement therapy. We need to get them in with their nephrologist. We need to partner. And in doing so, we can actually save kidneys, as kidney function, and prevent dialysis and all these other downstream effects. So ultimately it comes down to early diagnosis. And much of this comes down to know your family history. Now, it's really difficult. And as I'm sure you've heard many times, a lot of patients will say, well, I have a family history of heart attacks, or, they assume it's coronary disease and people get a stress test with their general cardiologist or even a heart cath and the arteries are normal and we're done. I don't have heart disease. But oftentimes, do we really know what our family history is? Have we gone and mapped it out? Did that young uncle really just drown or have a car accident, or what was the circumstance there? Was this really just I had a heart attack and somebody passed away, or was this a sudden arrhythmia due to an underlying cardiomyopathy? And the sooner we diagnose that, the more family members we're going to get earlier. So it's all about prevention and education. It's a bit scary, but knowing now that the vast majority of patients with HCM have normal lifespans and quality as long as they've been risk stratified, as long as they're seen and they're followed closely in a center. There's a lot of positivity, but it all comes down to education, detection, and knowing your family history is, I think, that very first step.
Could not agree more. We are working on some big projects right now to create a family heart health history app that will hopefully be available in the coming weeks. We are focusing it in our All Hearts Collaborative project, but it will have utilization well beyond that, so that we can help people all over the world start to evaluate what am I at risk for? What should I be talking to my doctor about? So knowing why your heart is thick is really, really important. Knowing if you have these diseases within your family are important. And knowing that the HCMA Center of Excellence Network now counts 56 programs among our partners, and we have the Pacific Northwest now covered very well. We are going to continue to grow our network to ensure that the model that we developed over 20 years ago, there's what we call the legacy programs. Those were the ones that were already existing. That was Barry Marin's program back at Minneapolis Heart, which then kind of converted to the Tufts program, the Leahy program historically, and then Mayo and Cleveland, and used to be St. Luke's, and now it's NYU. So there were these core places. And now we've worked to find wise clinicians like yourself with a passion for HCM and genetics and thick heart muscle disorders. And we've grown that network out to 56 programs right now, adult and pediatric. You will see more coming from us. There's going to be another 3 launches of programs over the next couple of weeks through Heart Month, which starts in less than 12 hours. And we're going to continue to make sure that patients have access to high volume quality care to ensure that every tool in the toolbox, clinical trial opportunities, high volume surgery, either referral or in-house, either one is fine. We need to make sure patients are getting safe care, effective care, and that they don't have to travel by plane, train, and automobile simultaneously. Hopefully we can pick one mode of transportation for them and get them into the care that they need. And the lessons learned, as you clearly stated earlier, from use of telemedicine through COVID, we need to make sure that that remains possible. It is a highly effective means of delivering healthcare. It's cost and time sensitive, and management issues related to the physician's time, the patient's time, commuting, driving, going. Let's be smarter, not let's work harder. Let's work smarter in getting patients the information that they need. And yes, sometimes, ladies and gentlemen, you got to drive to the big center because the imaging quality is so much better than your community imaging. So yeah, that's where we're going to still have you travel. You got to go to the centers to get your stress echo, your MRI, and you need hands on you to evaluate the whole you, probably annually. But the use of telemed between, I think, is going to be really a game changer for some more remote regions. And you got a lot of those.
Lots of those.
Yes,
Yeah.
you do. I am going to bring up your contact screen again. At least I think I'm going to. Oops, I just lost it. Let's find that again. There we go. And this is the Virginia Mason Center of Excellence, HCMA, Recognized Center of Excellence. Contact information, your phone number is there. vmfh.org/HCM for their web presence. You can also find them on the HCMA directory listing for hcm.org, where you can choose the Find Care button and take you to the directory listing. So you can, if you aren't sure how to get all of this information, you can contact the HCMA anytime. We'll direct you. But what is the lead time for a new patient appointment at this time?
We should be able to get you in within a few weeks. And that is a 60-minute new visit. I'm speaking on behalf of me. I will not necessarily, I don't have as much, I'm not boots on the ground at some of our other sites with some of my colleagues. But with virtual care, you should be able to get in with me virtually or in person within a few weeks for a 60-minute consultation. And sometimes we do that. We start virtually because it's a long way to drive. And other times, if I have a lot of referral documents, I've had a chance to review them, I'll say, hey, if you want to come in person, we can schedule this, and this all on the same day. If you're interested, and Alec, my nurse coordinator, can kind of go over the rationale as well. So it's a choice. Either we can have that initial conversation, go into what we're thinking of, what your goals are, what my, responsibilities are, do that counseling, and then have you come in for what I like to call the spa day. So for those patients coming from far, we try and do all of it in about one day based on what they're interested in. And if we're going to do that, it might be pushing back things a little bit. But oftentimes, especially if you're interested in a virtual appointment to just go over that story together, it's really an opportunity to learn more about the disease state. Oftentimes I encourage, this is the nice thing about virtual too. You can have your partner, maybe your kids, a good friend, somebody there also as your eyes and ears to help hear this information and also share their perspective. And it really helps with the whole picture. Again, it's not the same as if I have you in the office with me where I can show you all the models, some of our posters, I can put the stethoscope on, but we learn a lot and we start building that relationship and we put that individual story together in that initial consultation that can be done virtually.
I like how you set that up, that this is a relationship. This is not a transactional event that happens once and we're gone. Our hearts are with us forever. So we want to find a team who can grow with us, who can understand our goals. Some people may have very specific goals related to exercise and activity. Some might just be looking for, how do I get through the day and reserve my energy for the things that I want it for? And how do I find some more energy or stamina with this wonky heart that I've been given? So setting expectations, what am I looking to accomplish? What's important to me as a patient? What are the options that are available in terms of treatment that I might not know about?
And it's so different for every person. And so I do like to always start the visit by asking my patient who I'm meeting the first time, tell me a little bit about why you think you're here and what is it that you want to get out of this visit? Tell me your story. And it's amazing how much I learn just in those first few minutes. And sometimes patients have done all their experience. They've talked to you, Lisa. They've done all this testing. They've they've done a deep dive and they know exactly what they're interested in. I'm interested in this one clinical trial, or I really want to switch from this medication to that medication. Or it might just be, I really want to get my kids in for genetic testing and I need to get tested again because I can't find my result, or something very granular and focused. And other times people are like, I don't know, my cardiologist said I should come see you, but I feel fine, but I think I feel fine. And then you kind of deep dive and you find out that maybe they're not so fine. And
yeah,
so
we're always good at telling you we're fine, but our definition of fine is not what a non-HCM hearted person would be thinking is fine.
Exactly. And some of the most rewarding parts of these conversations is when you have patients, and we know that it's many of them who've had symptoms for years, but it's only been recently where they've seen a cardiologist who says, hey, I think you might have this. I want you to go see so-and-so, see me. But for years, they've seen multiple providers. They've said they've had palpitations. They've been told that they have anxiety. They've said that they feel short of breath or lightheaded. Oh, well, maybe you're just out of shape. Maybe you're deconditioned. Or when they finally find the coronary disease, oh, it's just a coronary disease. The stent should have fixed it. I don't know why you still have symptoms. And that they just feel like this is how they're supposed to live. And so that validation and knowing, oh, wait, you mean it's not just in my head, that really there is something going on with my heart? And then the second part is, I'm pretty sure that we can work together to make you feel better and improve your quality of life. It might not happen overnight, might be a bit of trial and error, but that conversation is really rewarding, and to be able to get to that point.
I couldn't agree more. And my other arch nemesis is athletically induced asthma, but we've not done a pulmonary function test to show that it's your lungs.
Yeah. Right. And the amount of people who have induced asthma on your problem list for decades.
And it's always been there. And you're like, well, I just have a little touch of athletically induced asthma and this little heart murmur. Don't worry about it. Ding, 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 ding.
One of my biggest pushes is in the Pacific Northwest over the last few years is that education piece to other clinicians. That one, there's the referral pattern initially is waiting until patients are so symptomatic that you can't ignore it anymore, that you don't think it's just a little bit of asthma or a little bit of deconditioning. So bring those patients in sooner. But the other part is all these patients who have a label of hypertrophic cardiomyopathy on their chart, and they say they're fine, and there are clinicians saying, okay, well, you have a little bit of AFib, checkbox. Oh, you're HCM, you're doing okay, you're working, you're able to do the carpool with your kids, you're able to travel. Okay, you're fine. We don't need to do anything. You have a mild or a benign form. How many of them are one mild? I don't know if we haven't done up-to-date risk stratification, right? And it's a progressive condition over a lifetime. So maybe you did have it all, maybe even at a COE 10, 15 years ago. That doesn't mean you're necessarily fine now. But then the second part is, are they really asymptomatic? How many of them really are mild and it's just fine? It's just the way they are. So I think every patient should come in and they deserve a consultation, even if they think that they're doing fine.
I go back in my own history at one point, many, many, many years ago, as we were just figuring out genetics. Somebody told me once, oh yeah, you have the gene and these family members have the gene. It's pretty benign as a gene. And it turned out that, it's not. In my family, I've had 2 sudden deaths, actually 3 sudden deaths, heart failure deaths, kidney failure, stroke. Like there's been a lot of stuff out there that's not, and my heart transplant. So like, that's not benign, but for periods of time, we feel okay. And sometimes we get comfortable in feeling okay or ignore our bad days. Let somebody come and assess you. Let's make sure you're really as good as you think, or maybe there's some more room for you to even feel better than you feel now. Let's figure that out. Let's get you aligned with a center. And now if you are in the Seattle area, you have some options, and Virginia Mason is one of them. I'm going to take down the slide right now, but they kept it up there for some good long time. So hopefully people got an opportunity to see that. And this is going to be put into our newsletter so that the people who didn't see this live have the opportunity to learn about Virginia Mason's new program and meet Mariko. and get to know who she is a little bit. So what else do people need to know about you before we end this session?
Well,
You have
I'm
an interesting background. Come on.
a little bit of background. I mean, I'm a mom of 3 kids, so I'm juggling a lot. I'm trying to learn how to play tennis in my 40s, which is hard. So I hear it. I've got the exercise reduced asthma, and I think it's just deconditioning on my part. Um, but I have a background in some genetics and HCM training. I'm an imaging cardiologist. I really enjoy working as part of a collaborative team. I think our program is great. The Pacific Northwest has so many opportunities. We're getting involved in more and more research at our own institution, looking at our patient demographic, which might be a little bit different from other patient demographics, right? So I think it's really important that we all are involved, and we're looking and we're catering as much as we can to the patients that we serve. And we have to be very careful when we're extrapolating from data from patients that may not be as generalizable. As a clinician, I'm in clinic 3 to 4 times a week. So you'll see me around. I do procedures, and all of us actually, we're all on, at least in the Seattle campus, we're all on one floor. So we hang out, and we're a pretty close-knit, fun bunch of people. And I'm really privileged to call them like my friends and my program builders. Jill Jezrin and I share an office, as you know, and so we're often on top of each other, but we're always building and coming up with cool new things to try and bring to our patients.
I have seen that.
About it.
I have seen that. And as a reminder, HCMA conducts in-person site visits. So we've met all the members of the team. We've seen the logistics. We've seen where the buildings are. We understand the catchment area a little bit better than before we do a site visit. And you're going to have more options in Seattle. You have not had this before. You haven't had this level of attention on HCM in the Pacific Northwest. I know when we did our meet and greet, somebody flew in from Idaho. I'm like, is that like a thing? And they're like, oh yeah, we do it all the time. I'm like, okay, I didn't know that. When I fly someplace, I'm pretty much going pretty far, but this is just the way they travel there. I did not know. So as we grow and as our advocacy efforts grow in the region, you will hear more from us. You will see us more on the West Coast. You will see representatives. If you are an HCMA member or a patient with HCM and you want to get more involved and you want to join our ambassador program and be an ambassador in the Pacific Northwest, let us know. We'll give you the tools to be successful in your endeavor. So Mariko, it has been great getting you launched officially, welcoming you to the team. Yay. Woohoo, we did it. And we did the podcast, we did the launch. Let's go find all the patients and help them.
Sounds amazing. That sounds like a really good goal for 2025.
I like it for 2025, and we will be in Seattle in July. So stay tuned for the save the date card, and then the agenda will be up shortly thereafter. Thank you all for joining us for this live launch of Virginia Mason with Dr. Mariko Harper. This is Lisa Salberg signing out from the HCMA, reminding you that Heart Month starts in less than 10 hours. So post your stories, share your experience, raise awareness about HCM and heart disease in the young. Let's talk about it. Let's change it. Okay, Mariko, thanks so much.
Thanks, Lisa.
And ending.